Hello, my name is Anthony Effinger, and I'm the host of the Think Neuro podcast. And today I'm sitting down with Dr. Shanthi Garinathan, who is the director of psycho-oncology here at Pacific Neuroscience Institute. Thanks for joining us.
You're welcome.
So tell me, what is psycho-oncology?
Psycho-oncology is the field of treating all the aspects of cancer that are not directly related to medical care. So that would include behavioral, psychosocial, spiritual, and physical symptoms that affect quality of life, like pain.
So you're trying to help people get through this process in a mentally healthy way.
Yeah, get through it and also sort of recover from it, rise up afterwards because there's a lot of losses that are involved along the way.
So what is psycho-oncology?
Psycho-oncology is the field of cancer psychology and cancer psychiatry, and we address the aspects of cancer that don't come directly under treating the cancer itself. So spiritual issues, physical issues such as pain that might affect quality of life, insomnia, cognitive issues, and then we also address behavioral, psychological, and psychiatric issues like depression and anxiety.
Well, you said spiritual issues.
Yes.
Is that dealing with the higher powers, helping people to tap those sorts of strengths, or?
I think it's whatever spiritual means to that person. I think for some people it definitely means religion. It means having a faith and using that to get through this time. It's a very scary and uncertain time, and I think having faith does a lot to help people bear that. But for some people, it doesn't mean God or religion. For some people, it really means tapping into their own strengths in their body. People have spiritual beliefs about nature that can be very helpful. So really, just like every other part of psycho-oncology, it's really about meeting that individual where they are in that aspect of their life and making sure that we have that as a support during the time when they're going through acute treatment and after acute treatment when they're recovering.
Are there things that come up as a result of the treatment, physiological things that happen in treatment that affect brain health, in addition to emotional things just from the process?
Yeah. So, I think people are surprised to realize that in order to survive cancer, there are losses along the way. And a lot of those losses are related to what we do to treat cancer. So people can get chemotherapy, they can get radiation. Now we have this wonderful thing called immunotherapy. And these therapies are helping people survive cancer and live, but they don't come for free. So we have cognitive symptoms. People can have changes in the way they process information, changes in the way their brain thinks, changes in mood, changes in behavior. And this can be very disconcerting for someone. You feel like you're kind of losing yourself in the process. And then when you get to the other side, not only do you have to get to know yourself again, but we have to address some of these losses so that you can function.
Are the losses both permanent and temporary?
I feel like the large majority can be reversed to some extent.
Oh, that's good.
If they couldn't, I don't think I'd have a job. So they are reversible to some extent because we do, sometimes we're using medication. Here in the Brain Health Center, we also use behavioral interventions, and we use new therapies such as cognitive fitness, which is combining exercise and cognitive function testing to help people's brains grow and sort of reboot themselves. One day soon, we're hoping to use psychedelics for that same purpose, to reboot the brain. I think there's a million different ways of doing it. Medication is one modality, but we have a lot of ways of helping people get their brain back.
So it really is, it's rebooting the brain?
For some people. I think for some people who have, sort of severe or intractable symptoms, there's a feeling that the brain is not yours. It's, this is not how I was. I was really good at math. I was really good at multitasking or dealing with people all day long. And now all of that is too much for me. Or I'm very slow at it, or it makes me nervous to try and do it. So,
And that's enough, right? I mean, feeling nervous about something that was your...
yeah, I mean, these are a huge part. Our intellect is a huge part of our identity. What we do for a living and how we do it and how good we are at it, that's all part of our identity. So these are things that I try to give back to people. And we succeed for the most part.
Is everybody different in this case? Like one person's going to react to chemotherapy differently from the next, or is there anything you can sort of predict about, say, how chemotherapy is going to affect cognition?
Well, I think it's a lot like people in general. There are general themes, and there are general things that, a patient will come in and complain about something, and I'll be smiling and nodding, and I'll tell them, I'm smiling and nodding because you're not the only one who comes in and complains about this. I get this all the time. So in that way, yeah, there are themes, there are things that happen fairly frequently, and we know where they're coming from, and we know how to treat them. But then, yes, each individual is different, and each individual sort of encapsulates this experience differently. It means something different to them. Some people cope just fine and don't need any help. They have their supports, they're okay. And other people, even if it's stage 1 cancer, just can't seem to sort of recover from this. And those are the people who are my favorites because I get to help them do that.
Because you can help there.
I do, yeah.
You said an interesting word. You said encapsulate this experience. Is that what's happening? I can imagine that.
So I have a lot of silly metaphors that I tell patients.
Well, I bet they're not silly.
Because I want them to separate themselves from the cancer, and it kind of gets twisted up because it's in our body. We understood that these are cells that were from our body, and so it gets twisted up in your relationship with your body, your relationship with yourself. Did I do something wrong in order to get the cancer? Is this a punishment of some sort? So I try to use language that separates the cancer from the human being, because none of us deserve to get it. None of us, sort of brought this on ourselves, no matter what we've done. It's not something, and it's not a useful concept to blame yourself while you're going through cancer.
Oh, God, no.
Yeah.
No.
So, yes, I use words that tend to box up the cancer experience. My goal for patients is to be able to box it, put it on a shelf. You can take it down every once in a while and review it and be sad and have feelings, but it should not be coloring our world. It should be nice and neat in a box.
Every day. Yeah,
I hope, eventually, because you can't move on otherwise.
So what do you expect, or what can one expect to have happen with chemotherapy, say?
So with chemotherapy, it depends on which chemotherapy. It depends on which cancer you're treating. But generally, there's a concept called chemo brain, which is kind of in quotes because it's not an official diagnosis. But, patients can experience what we call frontal lobe dysfunction. So frontal lobe dysfunction is the frontal part of the brain, which is doing executive planning, sort of higher level thinking, the part of our brain that we need to be able to function optimally every day. I like to think of it as the personal assistant sitting there taking notes and doing all of that, organizing ourselves. That is very sensitive to chemotherapy, it seems like, because there's people who come in and they may have tolerated chemotherapy very well, but then this frontal lobe dysfunction is stopping them from being able to go back to work. Or, one of the big things people complain about is they get irritable with their family, which they never did before, or they cannot stand loud noises, or they can't go to places with lots of people and noise. And so there's this almost like the brain has been traumatized and it's irritable, and it's not tolerating anything very well. Everything that it used to tolerate just fine now is a bother.
Is that all a function of that frontal lobe?
I think we have to assume that the chemotherapy goes into your blood, so we have to assume that the brain is globally affected.
Okay.
But these functions, yes, are housed in the frontal lobe, and these are the functions that people present, and it's very sort of debilitating to getting back to your life. You can't tolerate what you need to tolerate to get on with your day.
So what do you do?
I treat it.
How? Or is that secret?
Well, I think the first therapeutic thing is just telling people, hey, this is a thing. This is a thing, and it's not just you. I have plenty of patients with these symptoms. This is where it's coming from. just validating that person's experience. They're not crazy because they're yelling at everybody and kicking the dog and they can't understand their reactions to things. They're not losing their mind. Even that reassurance and that understanding, so sort of psychoeducation, that is tremendously helpful for people and for families. If I can sit with someone's wife and say, hey, he's not yelling at you because he's suddenly turned into this horrible person or he hates you. He's yelling because his tolerance is very low. And his ability to tolerate frustration, his ability to tolerate you talking to him while the TV's on, it becomes too much. Even that helps people to understand what's going on and helps their spouses and their families to understand. So that's very therapeutic. We use medications as well. There are medications that are sort of quieting to the frontal lobe. One of those is something called Neurontin or gabapentin.
Oh, I know that one. Yeah,
Yes.
that's
And it was
widely used, right?
Yes, and it was in the news recently because there were some issues with respiratory depression, and so my patients came back in and were very nervous. I'm very careful. I use very low doses, and we make sure that people are not on things that are going to put them at risk for sort of respiratory suppression. But I think that sometimes we need a little bit help.
Oh, absolutely. Yeah.
A little bit of help.
How does that work? How does Neurontin work in this case? Is it too complicated to explain to a journalist?
So Neurontin is actually in the anticonvulsant class of medication. It is too weak to be an anticonvulsant for the most part. It's a very sort of mild medication. It has this dosing window that's huge, from 100 milligrams. We've got people on 3,800 milligrams, almost 4,000 milligrams a day for pain. So patients feel comfortable because they know that this is something that, we don't have to worry about dosing. And I tend to let them find the dose that works for them. I give them guidelines, and then they get to take it as needed and see if it helps. So there's a tremendous amount of control that the patient has over this medication because I don't have to tightly control the dosing. There's a therapeutic window that's large enough that they can say, you know what, I want to take one more right now because I feel like I need it. And again, reestablishing control over your own behavior feels really good, without making someone dependent on it. Just being able to reestablish control and know that today you're not going to lose it because you have your medication and you're going to be okay.
You can reach for something. You can, right?
Yes, and I know that to some people seems like an easy way out, but it's not. You can talk to my patients. It's not an easy thing to take a medication.
No.
It's only happening because it is the way that we reharness the brain and get the brain to start to behave a little bit better.
And so what can people, do you see progress over time?
Yeah.
Yeah? How long are we talking about?
For gabapentin, I would say within a week to 2 weeks, people are feeling better. Yeah.
Really?
Yeah. Yeah. And then it continues to have effects for the next couple months. Yeah.
And so when somebody goes through chemo, I know this is speaking very generally, but when somebody does go through chemo, what, on average, how long before they start to sort of feel better and
well, it
do they get back to their full capacity?
It's so hard to say because everybody's so different.
Yeah.
Chemotherapy, radiation, some people tolerate chemo well, but not radiation. Some people tolerate radiation and not chemo. Some people, the immunotherapies are fine. Some people, the immunotherapies have a lot of side effects. Immunotherapy in general is fairly well tolerated, but even the immunotherapies come with some psychiatric fallout and also fatigue, which people find incredibly debilitating. Yeah.
Yeah. Just to define immunotherapy in this case, we've talked about it with some of your colleagues, but it's trying to get the immune system, right?
Mm-hmm.
To
We're
respond.
waking up the immune system.
Okay.
Yeah.
Okay.
We're waking up the immune system, and it's kind of like bloodhound dogs. We're giving it the cancer to sniff, and then we're sending it out to go find it. That's really fun to visualize, actually. But yeah, that's what immunotherapy is, waking up the immune system and harnessing its power and sending it in a specific direction, basically.
And with that comes some fatigue and some...
Yeah.
Is it fatigue from having your immune system working harder?
Yeah, well, it's like when the day before you have the flu, that feeling that you have, because your immune system is waking up and starting to fight this bug. By the next day, you'll know. But that first day where the immune system is kind of waking up and you feel kind of draggy, draggy every day for a long time can be hard to take.
Yeah, I know that feeling you're describing so well from, especially when you're younger and or a kid, you're like, oh, I don't feel good.
Yeah.
That's what that is. Okay. What about radiation? What do you see the same sorts of things with radiation?
I think the hardest thing for patients with radiation is, you can irradiate your big toe, and you can have effects in your brain.
Really?
Because of the way that radiation works and the fact that it releases these sort of inflammatory mediators in the body. And the brain is very sort of diva-like and doesn't like to be messed with. And these things are upsetting to the brain. So these experiences, that whatever's being burned away with radiation, the brain senses that based on the body's stress, because all this is communicated to the brain. And yes, people will come in and they will have only had radiation and they will have symptoms that are kind of whole body symptoms or brain symptoms.
No kidding. What did you say radiation releases?
Inflammatory mediators?
What are those?
Let's see.
Or is that too complicated for a journalist?
I don't think anything's too complicated for a journalist.
Well, you don't know me.
I've never met one before, but you seem fairly bright.
All right, well, anyway.
So basically the body's stress response, sends out these communicating chemicals. And the communicating chemicals go all over. And so the brain gets the signal too, oh, there's a giant stress happening somewhere. Maybe in your big toe, but there's a giant stress on the body happening somewhere. And while this is good for survival, because the body needs to know, and the brain needs to know if there's a stress going on somewhere, those same inflammatory mediators, when it's sustained or when it's over a long period of time, can change the way the brain works.
Change the way the brain works.
Yeah. The brain does not like this level of stress over time.
So what happens?
So the brain, in layman's terms, the brain becomes a little irritable, a little bit mad about, swimming in stress. We know that stress is not good for the brain. High cortisol levels are not good for the brain.
No. Is this producing higher cortisol levels too? Or is it something like that?
Well, mostly it's something like that. But everything that we do in cancer, from the moment we walk in and say the word cancer to the patient, is producing high cortisol levels, right? Because this is a level of stress that we don't experience in regular life. When someone goes, guess what? There's a murderer. He's trying to kill you. Also, he's in your body and you're going to walk around with him. You can imagine that for people, this is a level of stress that we don't experience in everyday life.
Not at all. No. Okay. So that triggers cortisol.
Yeah, absolutely. Yeah.
Wow. So that's a great way of thinking about it. It's from the word go. This is
from the word go. This is not a normal life experience.
And there's more to come and more to come, and hopefully then it ends, and you start to feel better, and that's where you come in.
Yeah. Well, I come in anywhere you need me.
Is that
anywhere
right?
Along the way. Yeah.
Yeah. When do you normally engage with a patient? Like what point in the journey?
There's really there's no set way. With the breast cancer patients, I tend to see them after they've had their surgeries, but there's some that before surgery they're really anxious, and then I get involved early on. Or if they're making big medical decisions and they need some help with that because they're kind of stuck. The anxiety can stop us from being able to make those decisions properly. So I never want people to be making decisions from a place of fear. So I try and help people with that. With other cancers, I get involved at different stages. Brain tumor patients, it really runs the gamut, but often it's after surgery, after treatment. People are put on steroids. Steroids have a lot of psychiatric effects. Depending on where the tumor is in the brain and what they took out, you can end up with cognitive effects, speech problems, problems with processing or communication. And all of those things can be so daunting that people do become anxious or depressed from it.
So what else do you have in your toolbox? And I imagine it's large. Beyond Neurontin, you mentioned exercise. Mm-hmm. What else? Or we should talk about exercise.
I think we should talk about exercise.
I think that it seems to be the great, it's absolutely, what do we call it? So one of your colleagues called it a poly pill. It's got everything. Mm-hmm. So how does it come into your world?
So there were some recent articles actually talking about how exercise is actually medicine in cancer, and we should be thinking of it that way. And I think the old model, before we got better at treating people without making them as sick, the old model was that when you treated the cancer, people were so sick that the ability to be mobile was not really an issue. People didn't have that ability. But now we have these modalities where people really tolerate the treatments much better. They're able to go about their day. There's a couple of bad days, and then you're back to business. And so we have to revamp our thinking about how we encourage people to go about living. And one of the things is if you were sedentary before, we really do want to push you to sort of start to exercise because we know how good that is for the body and the brain. It helps with tolerating pain. It helps with your cognition, improves blood flow to the brain. It keeps depression and anxiety at bay for some people so that they don't need treatment with medication. So there really is no true justification outside of issues with mobility and being very, very physically ill. There really is no reason why we shouldn't be thinking of exercise as part of the prescription.
I'm gonna go for a run right now. No, it's that kind of thing, though, right? I mean, it's that kind of thing. It's
Yeah.
just it's such a powerful drug.
Yes.
Okay, so we got exercise. We talked a little about drugs. What else? Diet?
Nutrition, we call it nutrition, and that is part of our cancer support team. We have really beautiful people who are experts in nutrition in cancer. And I really think that that's another place where we could do better, because there are ways of nourishing the body to make it so much better when the body is going through chemo and radiation. Obviously, people have nausea, they have vomiting, they have changes in what they want to eat and whether they want to eat. But if we can support that, then you can really look at how you were living and you can make changes.
Yeah. Sort of a
I'm not a believer in people judging themselves and being like, oh, I did this and that caused cancer. I ate red meat and now I have cancer, or I smoked and I have cancer. But I do believe that it can be a huge impetus for change, and that's actually a really good thing.
oh, absolutely.
You know.
So when you say we could do better, you mean as a society or as
I think as physicians treating cancer, I
Yeah.
think that unfortunately nutrition is something that is not really paid for by insurance most of the time.
of course.
We have here at St. John's and at PNI, we have this lovely, lovely philanthropic, sort of philanthropic push, and so we've been able to pay for people to get nutrition. But I think
Nutrition, like a nutritionist, somebody to
yes,
work with
nutrition
them
consults, where the nutritionist can look at your specific body and what's going on with you and your cancer and come up with a plan of how to best optimize your nutrition. But yes, there are lots of studies that also show that the way we eat can really help us in how we recover from cancer, the rates of recurrence. We have studies that show that as well. So it's just a matter of getting it more ingrained in the sort of
the system.
general thinking so that one, it can get paid for and be affordable for people, and two, as physicians, that we really do put an emphasis on that. Yeah.
Yeah. I know people who once they have cancer, they come out and they've suddenly discovered blueberries, pomegranate. I interviewed Mike Milken once, who went through prostate cancer, and he offered me a blueberry pomegranate arugula shake.
Okay.
And it's like, so I mean, I think people, to your point,
Mm-hmm.
people get the message and they make these changes and they start to think, hey, what am I putting in my mouth?
And whenever it comes, it comes. But
Yeah.
these kinds of changes, they stand us in good stead no matter what. So if cancer is the impetus, and cancer is the impetus, and then we make change. So
Run with it.
our job is just to make the change process available to people, allow people to get the education they need to do this the correct way.
Sure.
I think that's where we need to be.
So how long has the field of psycho-oncology been around?
Oh, I think it's been around for more than 30 years. But what made it gain traction is the fact that we have people surviving cancer so much longer now. I think before in the 60s, we didn't have a lot to help people survive cancer. And now that we do, it becomes about, getting people well. But then the second half is getting people to thrive after they get well.
And so who started this movement?
So
who started the profession?
Jimmy Holland Dr. Jimmy Holland is credited with being the founder of psycho-oncology. And it was this recognition that there are all these other factors outside of, the patient's actual medical treatment that really affect outcomes. Psychosocial factors. Who do you have in your life? What's going on in your life? Behavioral factors. Do people have coping skills, or do they have a lack of coping skills in general, coming into cancer? And spiritual support, social supports, the ability to properly treat pain so that people can get back to their lives, and emotional suffering. And then the sort of larger psychiatric issues like clinical depression and clinical anxiety disorders that can crop up as well.
Those aren't the things, I think, especially, back in my day, those weren't the things that came up when you thought about treatment of cancer. It was the sort of, let's see, high risk procedures or whatever. But this sounds more like, we're getting smart, right? Aren't we getting smart? Like we are about all these things, right?
Well, if sort of my typical patient would be a breast cancer patient, which unfortunately I do have patients who are in their 30s or in their 40s. They have young children. There's people who need to be dropped at school. There's people who need to be picked up. There's meals. There's, coordination of care. So, even when they're not feeling well, there is this tremendous pressure to get back to functioning. And unfortunately, in breast cancer, for many of the patients, even after we've gotten rid of the cancer, there are these medications that we put people on for 5 to 10 years to prevent the return of cancer. So that's 5 to 10 years that you're on a medication. Most of these medications have the potential for psychiatric side effects. They can make us irritable. They can make us tired. They can make us have pain, actually. Body aches, and definitely anxiety and depression or insomnia. So if you're going to ask somebody for 5 to 10 years to struggle with this is the large majority of their children's childhood. This is the large majority of their mothering years, or they're taking care of these families. And, they don't want to be robbed of those experiences because they don't feel well the whole time. And that is why it's very important for us to sort of, surround them, support them in any way possible, get them back to a place where they can be who they want to be.
That is
at home and at
I
work.
hadn't thought of that, but 5 to 10 years, of course, you've got to support on those kind of drugs that.
They're very brave ladies, but
I can imagine.
It's very hard. Yeah.
Do patients tend to do the effects of the drugs, those side effects, tend to diminish over time? Do you ever get used to them? Do they ever?
For a lot of people,
Okay.
yeah, definitely. For a lot of people, my goal with a lot of people is really to get them to tolerate the medication long enough for it to settle. People, it's kind of a moving target. Symptoms change. Some people have no symptoms, and then later on they start to develop symptoms. Some people start out with symptoms. There's a wide gamut of medications, so the oncologist can change medications if they feel like someone's not tolerating something. But again, the pressure is take this stuff so that the cancer doesn't come back.
Oh, yeah.
So you're not going to stop it, but it's very difficult to put something in your mouth every day and know that that is the cause of your symptoms. So
Sure.
we want to relieve some of those symptoms so that's less of an issue.
What's the most gratifying thing about your work? I can kind of guess, but
I kind of love all of it.
Do you?
I do. I love my work. I'm so lucky. I think the moment when patients realize that they may not be the same person as before, but who they are now is going to be great. That is a really nice moment, when they finally see the light at the end of the tunnel and, okay, there were losses, I am different, but this is going to be great anyway. I live for those moments.
When they get to that point and they see it.
Yes.
That has got to be.
It's amazing.
Yeah. And that must happen at different intervals
It does.
from
yes.
the time of diagnosis and treatment, right?
Yes. And, even if people aren't getting better, it's just such a privilege to be able to walk with them while they go through this. I mean, even if the cancer stays, even if we pass, I get to be there, and I get to make sure it's okay.
How did you get into this?
I don't know.
Well, let's see. So
the short answer is by accident.
Okay. But you med school.
Lucky accident.
Really? What was the lucky accident?
Well, I was in residency.
Okay.
And
for
psychiatry.
Psychiatry.
Yeah.
So I was trying to get back. So you went to medical school. Did you know what you wanted to do when you went into medical school?
Well, definitely not psychiatry.
Oh, really?
Yeah.
Okay.
Yeah. No, psychiatry.
And then what happened?
And I had an amazing mentor in the last rotation of medical school, the very, very last, the throwaway one before you graduate that you don't care about at all.
Really? Where was this?
This was in a place called Danbury, Connecticut.
Okay.
And his name was Dr. Sperling. I don't know if Dr. Sperling's around anymore, but if he is, I'm sending him love. And he loved what he did. And I had been struggling because I loved internal medicine. I got a letter from them saying I should be an internal medicine doctor. I had fun in surgery, and I have a letter that says that I should be a surgeon. But I didn't have a place where I could really spend time with patients and get into it with them, their stories. And I've always loved stories. I was a lit major, so stories are my thing.
Okay.
And then I found him, and I found this field where you get paid to sit with patients and hear their stories, and really delve into who they are. And I mean, from that time to this, it amazes me that this is a career that you can get paid to do this. It's just such a beautiful thing, and it's such a privilege. And I did veer a little bit towards medical psychiatry because I really did love medicine, and I do like knowing what the liver is doing and the kidney's doing and where the tumor is, and I like coordinating with the oncologists. I really like keeping that medical hat on.
Yeah.
It makes it slightly more challenging, but it also, I think, in some ways, cancer in particular, kind of burns away the nonsense, and you're able to get to the crux of what's going on with people so quickly. And there's this sort of opening, this small opening where you can jump in and start in the middle instead of sort of slowly inching there the way you would with sort of general psychiatric practice. So I find that really, really
very
exciting.
Interesting.
Yeah.
I'm sorry, what did you say about the throwaway part, the throwaway rotation? What did you said?
So at the end of medical school, right before you're graduating, you do a rotation to finish your requirements or whatever. But by that point, you've definitely got a bit of senioritis. You've already, applied for residency and done what you needed to do. So, and I actually wasn't going to residency because I wanted to have my first son. I wanted to have a kid. So I was actually not going into residency. So this was really a throwaway rotation. I wasn't going to do anything. And then I met Dr. Sperling, and I think I worked harder on that rotation than I did.
And that rotation was?
It was psychiatry. It was outpatient psychiatry with a strong focus on therapy, and a lot of sort of very, very sick patients. And so, but he was someone who didn't believe that when someone was very psychiatrically disturbed or ill, that you couldn't still reach them and try and do some therapy and try and alleviate some of what was going on inside as a person, not just with medication.
Okay.
So he taught me how to do that. And I just thought it was like science and art put together, and it was humanistic, and I knew that that's what I was going to do once I was done having that first baby.
Sure. And this was this must have been it's just a surprise to you because you thought, I'm just doing this last rotation and I'm done.
Oh yeah, and I come from a culture that doesn't believe in psychiatry at all.
Is that right?
So, yeah, no, we don't believe in psychiatry.
What culture?
I'm Sri Lankan.
Okay.
Yeah, so our culture is a lot more about not talking to strangers about your problems.
Is that right?
Yeah. So no, we are not. At least growing up culturally, I was not taught to talk a lot about feelings, and I think psychiatry was a bit of a stretch from my
Interesting.
parents.
That's
Yeah,
interesting. What did they think?
didn't know what to
They're
think.
like, wait, what? They're like,
They're happy now, I think.
you think? Well, I'm half Italian, so that's all we do is talk about our feelings.
Oh,
Yeah,
okay.
but that's interesting. Okay, so then did you take time to have your first
Yes, he's
boy?
12.
Okay,
Yes,
and
he's 12.
then how long when did you then you went?
So after I had him, I took my last board exam. He came with me. And I did some rotations, and I knew I wanted to do psychiatry, and I got my first choice, went to Cedars-Sinai, and
Oh, congratulations.
learned the field of psychiatry very well. It was a
Yeah,
great
yeah.
training. Yeah.
How long is that?
4 years.
4 years. Okay.
Yeah, it's because it's a specialty. So 4
Okay.
years.
And then when did you start to focus on was that a residency in
That was a residency in psychiatry, all of
Okay.
psychiatry. Yeah.
Okay. So then you had to go back and do
No, actually,
Or
my
did you-
last year, my final year, I basically focused on medical psychiatry. So I went to UCLA and I did the women's clinic there. So that's learning about how hormones and different stages in a woman's sort of reproductive cycle, what that has to do
Oh.
with their, and it has a lot to do with it,
Yeah.
with their mental health. So we treated pregnant, postpartum, IVF, menopause, that kind of thing.
Okay.
I did ECT at UCLA. They were kind enough to let me do a rotation there and
What's
certify me.
ECT?
Electroconvulsive therapy.
Okay. So
And I did that just because I was very afraid of it and I wanted to understand it.
good for you.
Yeah. And I do understand it, and I realized that it has value.
Has a place, yeah.
Yeah. And then I did a lot of rotations in cancer psychiatry at Cedars, at UCLA. I did rotations in cancer psychiatry.
And then what initially drew you to that? It sounds like what's a progression?
I think medical psychiatry in general
Yeah.
was of interest.
Yeah.
And then, again, I met people who are very good at what they do. There was a doctor at Cedars named Dr. Wolcott, and he loved his work, and I fell in love with his work too. And I just realized this is a moment in a patient's life when you can make a tremendous impact. I think I must be an instant gratification girl because it's so much impact, and it takes so little time to be able to get in there and make that impact
Yeah.
because people really, really are at a crucial moment in their life.
Absolutely.
Yeah.
Yeah, they're open.
And that became a little addictive for me, the fact that you could make such a change and so quickly. So that, I think, hooked me.
So you've probably seen you've talked about you've probably seen some really profound change in people.
Yes.
Yeah.
Yes. Yeah.
Wow, that's fantastic. Well, and how long have you been at PNI?
Let's see, a year and a half almost.
Yeah.
It will be. Yeah.
You like it so far?
Yes. Yes. I moved here for a reason. I
What was
love
that?
it. Just there's kind of a light around this place. I mean, the doctors here are lit up and passionate about what they do. And I don't think that you can be unhappy working with people who are passionate about what they do. It just sort of creates this energy and this drive, and I'm just sucking up all their
the good.
all their energy, and and it drives me too. So.
Is it helpful to have people in different disciplines in the same kind of building on the stairways
yeah.
and meeting? And
The collaboration is,
Yeah.
I think, what I would want for myself if I was sick, because
That's
there's a synergy. There's like
it's true, right?
I want my
Yeah.
doctors to all be thinking about me and synergistically sharing ideas, and that's exactly what I would want for myself or someone I love. So,
Yeah. Well, there's all these theories about creativity, in meaning in the arts and in science, which are is an art in itself. But it talks about this mixing, this random. It's often random mixing. It really is just meeting somebody on the stairs that leads to breakthroughs, right?
It's in the hallway in clinic.
Yeah.
I'm in the cancer clinics, and in the hallway in clinic, you run into a doctor and you go, "Oh, hey, about your patient so and so," and in those 4 or 5 minutes, I think the human interaction is important. I think it helps us to validate each other's experiences, and it helps us to keep doing this work because it is difficult work. And then, two brains thinking together, come up with something that each separate brain may not have come up with. So
Yeah.
I'm a big believer in collaboration. I'm a big believer in, doctors who communicate. I love outside the box thinking when it's needed. And I think that when you put a bunch of doctors together, that's what happens. If we can't find a solution separately, then we start to think outside the box together. So, yeah, and I just, these are great doctors. I'm happy to be here.
I'm sure they're happy to have you too.
Yeah, I don't know. We'll ask them.
Dr. Gary Nathan, this has been a real pleasure. I thank you so much for sitting
much.
down with us.
Thank you.
Yeah.
I appreciate it.